What would your approach be to assessing the psychosocial needs of children and adolescents with psoriasis?
Well, when I'm looking after patients with psoriasis, whether they're children, adolescents, or adults, the most important thing to do is to listen to the patient. And we as healthcare professionals fall into the trap of worrying that if we ask about the psychosocial comorbidities of living with psoriasis, that we'll be there for hours or days whilst the patient talks to us. And research has told us that that's not the case. In fact, patients can be very articulate very quickly, often as quickly as just 4 minutes. So just saying to a patient, and how has this made you feel? What's happening for you at the moment? Is really the most important step in the consultation. Because in any consultation, there are two experts. There is the healthcare professional who has lots of expertise around medicine and the application of medicines for our patients. But then there is the patient, and nobody can know the patient as well as the patient knows the patient. So really we have to understand that in any interaction, any consultation, it is about the meeting of two expertises, the healthcare professional's expertise and then the patient's expertise. So just listening to the patient is really important. It's important really to ask open-ended questions if you can, but if you find that the patient isn't really prepared to be explicit about what's going on for them, then asking simple questions like, how has this made you feel? What goals do you have in terms of treatment for your psoriasis? What aims do you have from this consultation? Or has this made you feel upset? Or have you been having any difficulties around living with your psoriasis? Can be really helpful questions just to open up the patient to talk about exactly what's going on for them. Because we know that if we do use these techniques with active listening, nodding when the patient is explaining to us what's happening on, repeating back to the patient our interpretation of what they're saying to us, and using affirmative signals like I see, or okay, or right, will really engage the patient and make them explicit about what's going on for them at this particular time.
What signs and signals from patients are useful in assessing the psychosocial impact of their psoriasis?
When I assess patients for their psychosocial comorbidities when they come to me with psoriasis, I can use various techniques to draw out exactly what's going on for them. The most common technique is to ask simple Socratic open questions such as, how are you feeling? What do we mean by Socratic? We mean a simple question that has no binary, simple yes-no answer. It's a question that is open-ended and allows the patient to describe exactly what's going on for them. But you can, if you want to, give patients well-validated, often very well-resourced and researched questionnaires. For example, you can use questionnaires around quality of life, remembering that quality of life is entirely different from psychosocial comorbidities. So quality of life questionnaires such as the Dermatology Life Quality Index, the DLQI, is a 10-question questionnaire which has a maximum score of 30. And it tells us a little bit about what's going on for the patient's quality of life in that snapshot moment. If I wanted to, I could use other questionnaires like the Hospital Anxiety and Depression Score, the HAD score, and that can give us a good idea about anxiety and depression. I sometimes even ask patients about whether they feel suicidal or whether they've got to the point in their condition that things are so awful that they'd consider self-harm. And we as healthcare professionals sometimes shy away from asking that question because we fear that if we ask the question, we're going to precipitate more suicidal ideation, or we fear that we haven't got the capabilities to be able to deconstruct a suicidal ideation in a patient. And that's not the case. We do have the capabilities. we can easily say to our patients, okay, have you made any attempts? Have you had any thoughts about this? How would I make sure that you're safe? And the vast majority of the time, patients are very clear that actually they may have occasionally had thoughts, but they don't intend to act on those thoughts. But it is important to remember that if we talk about suicidal ideation for a patient who is feeling very desperate, actually you really reduce the chances that they're going to act on any suicidal ideation. And patients often feel a sense of relief about that. So really, in summary then, when I ask about the psychosocial comorbidities, I take cues from the patients if they're struggling to meet my eye contact, or if they're sounding very low and depressed, or if they're telling me that they're struggling with what they're doing with their life. I might ask them a bit more questions about, are they depressed? Could they be anxious? But then I'll talk a little bit about the quality of life, and I might even use a HADS score, Hospital Anxiety and Depression Score. Very occasionally, I might even ask patients about whether they've thought of self-harm. But it is really important that we embrace these questions in as sympathetic and empathic and helpful way as we can with our patients.